All right. Again, this is good afternoon. Again, this is Phil Pugh. We are going to get started shortly, and prior to us getting started, I'd like to do a quick roll call. I am recording this for posterity, and it will be uploaded to our coalition YouTube page. So please make sure you subscribe to that, so you can follow back up on this if you need to later, and use it as a potential primer for any other pediatric exercises or plan reviews that you may be doing at your organization. We're going to do a quick roll call here. And I noticed that there are a lot of folks that have logged on via Teams, so I can see your names. I will, I'll try to go down those as quickly as we can. And there's a list of you that have dialed in via phone. And some of you may be doing both. So if you are doing both, remember you got to mute one specifically and turn the volume down on one specific so you don't have any feedback if you do talk. But once I get to the folks who are logged in or who are called in, I will read off the last four of your phone number for you to answer to. So please just, when we go down, I'll give everyone an opportunity to state who you are and what your current position is at your organization, and if you have any additional team members at your organization that are participating. So again, I'll give my quick introduction. Again, I'm Phil Pugh, Director of Emergency Management and the Regional Hospital Coordinator and Hope Coalition Chair for the Edwardsville region. I'm joined today from at least with two of our staff members, Lee French, he's my right hand when it comes to all things coalition. He's the one that developed this tabletop exercise. He'll be your facilitator for today. I will be doing some grant related work in the background, but still participating at the same time. And we also have Scott Klosterman, who is our regional clinical advisor. He's a nurse here, works on one center, and he was the initial draftsman of our pediatric surge annex. So Scott took that task on when he joined the team, and over the past, I'd say, 3 to 5 months, we've matured that document as something that we're trying to validate, and this tabletop is a part of that validation process. So we are here. I'm trying to see if Leanne was able to join. She is actually working over at the collection site today, so I don't think she's going to be able to join. And for all the folks here, I will give you guys just a quick administrative announcement with our team. Leanne has applied and been accepted for a position still within BJC to be the site manager for our sample collection sites, our COVID sample collection sites across BJC. So she'll actually be starting that new position next week. So on August 24th, she will be starting her new role in that. It'll be much like what she's been doing a lot for the past 3.5 months during COVID. And she's going to be a great addition to the BJC team in that regard, as she was here. So she will be missed. So if you guys can shoot her an email, tell her thanks. And she's not going anywhere out of the BJC family, but she will be out of her current role as EMS and preparedness coordinator for Memorial Hospital East and regional exercise and support coordinator for the coalition. So that's a lot from me. I'm going to go down the list. Some folks don't have full names, so I'll start off with Annie. Annie says you're a guest. Could you say who you are, where you're at, and provide a little intro? All right. If you are muted. All right. And I think the next name is that Charmy Rainey.
Yes, this is Charmaine with Eastside Health District, Director of Environmental Health Programs. I'm also here with Tiffany, the Program Manager over Environmental Health.
Okay, thank you very much. Dale.
Dale Chambers, St. Louis Area Regional Response System, STARS. We administer the HVP grant as a contractor for all of Region C on the Missouri side, so a partnership with Hope there on your side. And then I believe on our phone today, we also have Sam Peterson from our team who is really focused on our training and exercise and other support elements with that.
Thank you, Dale. Jake.
Hey, this is Annie. I'm going to speak for, we were having technical difficulties getting our computers to work, but we work at the Calhoun County Health Department where we just got hired on as environmental health specialists. So we're just excited to join the team and learn.
Great to have you. Thank you. Jim.
Yes, Jim Loxton, Security Operations Manager at Memorial Belleville and at Memorial Hospital East in Shiloh.
Thanks for joining today, Jim. Hope you get something out of this.
Okay.
Lee will get plenty of opportunity to talk here in a little bit, so we'll skip over to Marcy.
Hi, Marcy Barth. I'm the Chief Nursing Officer at Fayette County Hospital in Vandalia, and I am actually filling in for Tina Evans, who is our Manager of Emergency Services and Emergency Preparedness Coordinator. She is out with a family emergency today, so I'm filling in for her.
Well, thank you, Marcy, for filling in for Tina. Tina's also our co-chair, one of our co-chairs, along with Terry Everett out of Bond County. We hope everything works out with Tina. And if you had to put me to a sound test, Marcy, you could have probably fooled me on a phone call. I would have thought you were Tina. So glad to see the accent doesn't travel too far from over there. It's glad to have you.
Thank you.
Mike Lauer.
Hey, good afternoon. Mike Lauer, Executive Director of BJC Emergency Preparedness, Environmental Health and Safety, and Security.
Thanks for joining today, Mike. I see a few OSF guests on there, so I'm taking it that Gary's can probably handle that, or whomever is at the helm.
Yeah, this is Gary Engel. I'm Security Manager and Disaster Preparedness Coordinator at OSF St. Anthony's Health Center. And I have a group of people. I think you guys, if you want to introduce yourself. Mark?
Mark with Environmental Services.
Mr. Bayanta with Director of Support Services. Corey Basil, Director of Finance.
Jeff Wormy, Supervisor.
Fred Sansucci, Manager of Imaging Services.
Becca, Manager of ICU and Respiratory Therapy. Talking, Manager of Specialty Services. Sister Michaela, President.
I don't know if you heard all that, but everybody made introductions. Can you hear us?
I sure can. We got that. I appreciate it. And the good folks up at OSF St. Anthony's, they hosted us one time for one of our coalition surge tests. They have a great team up there, and it's really, really good to see that you guys are all coming together for another opportunity to just better the coalition and better yourselves with regard to preparedness, specifically in the pediatric area where we do have some challenges here on this side of the river. So thank you guys for coming in and joining as a team.
Thank you.
All right, then we got Brad over at St. E's.
Yes, Brad Perry, Manager of Emergency Management and Preparedness, St. Elizabeth's Hospital, O'Fallon.
And Brad is, while not new to anything preparedness, but he is new in the role that he's in currently. While he does a lot of EMS stuff, now he's kind of officially the preparedness guy for the good folks at St. E's. So we're glad to have Brad participating as a longtime partner here in the region, especially on the EMS side. Now he's picking up a couple more reins on that side. So thanks for joining today, Brad. I think we got Samantha Peterson.
Hey, this is Samantha Peterson. I was introduced with Dale as part of the STARS team.
Gotcha. What's your role?
I'm a public safety administrator with STARS. Specifically, I'm currently working with Thyra, and then I'll also help out with training and exercises for the organization too. So for the St. Louis area.
Awesome. Glad to have you. I'll let Scott, even though I partially introduced him, Scott, if you would like to make an announcement or give a little bit of feedback and background.
Good afternoon, everybody. I'm Scott Klosterman. I'm a nurse on one center at Belleville Memorial Hospital. It's one of the med-surg floors. I've been the clinical advisor for going on a year now, I think, Phil. Is that right? Or
pretty close, pretty close.
Yeah, because I think I was the clinical advisor last June when we had the conference. But I'm kind of here. I'm kind of an available resource for anybody in the coalition. If you have any clinical questions, and I work the first week of the month, but I'm available every day. If you have any questions, I'm pretty much here to help.
Thanks, Scott. Sean.
Yeah, thanks, Phil. Sean Eisenhower, Emergency Preparedness Manager for BJC Healthcare.
Cool. Thanks for joining today, Sean. I see we got Sue Laughlin on.
Hi, Phil. This is Sue. I'm the Emergency Management Officer here at Staunton Hospital and the ER Manager as well.
Gotcha. Thanks, Sue. Sue is a big partner here in the coalition, does a lot also with our mental health resources, folks. So thanks for joining today. Now we're just going to go through a quick list of numbers. We'll try to knock this out and then we'll get started. Going with the last four of 9898.
Nancy Wollmever, Boyd Hospital, HPP.
Nancy, glad to have you back.
Thank you.
4604.
That is Greg Atterbury. I'm the IDPH Regional EMS Coordinator and Liaison IDPH to the Edwardsville Coalition.
Cool. Thanks, Greg, for joining. 6961. Going once.
I'm sorry, it's Kelly Angel with Greene County Health Department.
Gotcha, Kelly. That mute button is always hard to find when somebody just randomly calls you. I know. I lived that life. 5522.
Is Marcy Barth from Fayette. I've already introduced myself.
Okay, gotcha. So you're double logged on. Okay. 2528.
Jamil Rana, Pediatrics, Gateway Regional.
Gotcha. Thank you. 6516.
Eric Brandmeier, Anderson Hospital, Director of EMS and Emergency Preparedness.
Eric, thanks for joining today. 8449.
Kelly Birdsong, Jersey Community Hospital, EMS Coordinator.
Gotcha, Kelly. Thanks for joining. And we got two more. Last two. 1442.
Terry Everett, Bond County.
Gotcha, Terry. Again, Terry's one of our co-chairs for the coalition and Bond County Health Department. And last is 3000, which I'm predicting is Gateway, and maybe that's going to be Danielle and or Rick.
Yeah, this is Rick, Danielle, and about 10 other people, including Dr. Rana, that spoke earlier. I'm Director of Facilities and Plant Ops, and as well as Emergency Management.
Great. So just we won't go through all 10, but kind of give a summary of the folks you got in there, maybe just by just positions, the administrator, VVS, or clinical.
Respiratory, ER, security, infection control, quality, pharmacy, house soup.
Gotcha.
Pretty much it in a nutshell.
Rick's team is another one, much like the folks at OSF. When they come together for, if there's a regional exercise, tabletop or otherwise, they really do come together as a team and operate as a team in an exercise scenario. So we really appreciate the level of support that you guys provide to both the coalition and what you're trying to do to just better the team overall. So thank you guys for joining. Again, I'll give just a little primer to this before we get started. This tabletop exercise is twofold. One, it's going to fill an ASPR requirement for us as the grant. There was a requirement for us in our BP1, which was 2019 to 2020, June 2019 to July 1st or June 30th. 2020, that fiscal year, for us to conduct a pediatric tabletop exercise and validate our pediatric surge plan. So there were some things that kind of happened during that time frame. They kind of pushed things a little out of whack. We were trying to do this following our scheduled April ChemPAC full-scale exercise. But when COVID hit, we had to really readjust. So we've been granted some extensions to get some of this work done. And this is one of those things. Now, we've put together several different annexes for the coalition, and the pediatric surge annex is the latest of a few. So a few of the other annexes we do have a ChemPAC annex. We are working on a general surge annex and evacuation annex for the coalition, but this one is probably the newest and one of the requirements that ASPR is looking for. What we've tried not to do, and most of you should have copies of the surge annex itself, but just from a planning perspective, we have a emergency operations plan that covers how we will basically move throughout an emergency for the region, how we will contact folks. But we have support annexes that provide direction under specific either hazards or functions. So we have a tactical interoperable communications plan, which is an annex to it that gives you all of the communication priorities, the tones for EMS, gives you everything. But we don't, instead of making a 1,200 page book or emergency operations plan, we kind of parse all of these things out. And this is just one of those parses. The pediatric surge annex, it will be a first for this coalition, and there aren't a ton of them around in other coalitions. So ASPR thought that this is something that a lot of folks are lacking in and we want to be prepared for. So we developed this. And the way that for those of you who have taken opportunity to provide comment, which a lot of the folks that are on this phone have reviewed the annex, provided us comment, and we've updated them. And I've sent out the latest update just before this. So if you want to peruse that during, some of your discussion periods, you will have that opportunity. But everything that we put together is not, I want everybody to understand, is not directive in nature. While we are the regional hospital coordinator, we're still a resource hospital for our system, just as a lot of you folks are. You guys are a resource hospital for your system. I cannot tell Gateway what to do. We function as a multi-agency coordination system, and we help you get whatever job you need done. So as we've been going through COVID, we've helped provide equipment or supplies, those needed items where in the healthcare sense that are primarily needed. We help coordinate different things, whether it's working with the SMOC across the river, bed counts, numbers with COVID. You guys seen day to day the information that we pass out, but I can't tell an organization, I can't tell Sue's hospital what she can or cannot do. You guys are all independent agencies. So I would like you to look at these annexes and the plans as our roadmap on the best way that we can work together. So a lot of the folks that attend coalition meetings have probably heard this before, but for those that have not, I want you to get that understanding that we can't direct anything, but we can help along the way as best as possible, and we can work together to solve whatever problem there is. And we've got a lot of those mechanisms built into how we operate from the state side down to our region, and that's what our plans are designed to do. So with that said, I'm going to start to stop talking now, and I'm going to turn the reins over to Lee so he can get us going here. So Lee, without further ado, please introduce yourself and get us started.
All right, thank you. Yeah, I'm Lee French. I'm the preparedness coordinator for Memorial Belleville. I'm also the person who created this and did most of the editing on the plan itself. So if there's I'd like to thank Danielle Rahman from Gateway. She provided a very detailed list of my issues with grammar. Hopefully they've all been fixed. So if you find anything else, please let us know. But we'll go ahead and get this going. And so just as a general overview, all we're going to do today is a facilitated kind of discussion, really. We're going to target some things, try to figure out where do we stand. This isn't just to focus on the coalition surge plan. This also should be triggering some thought within your internal plans, because like Phil said, we can't dictate what you do or don't do. Hopefully you have plans that can accommodate that, whether it's a disaster that strikes at 2 a.m. on a Sunday morning or noon on a Thursday. This is just kind of to get that kind of out there and see how it plays. So the scope of this, this was originally a 4-hour. We chopped it down to 2. The modules that we're going to look at, primarily we're going to start off with kind of the intelligence and information sharing. When we see something starting to happen, what are we going to start to do to spin up for it so that we're not broadsided by the bus? Once that bus gets here, we want to start looking at that medical surge. How are we going to cope with that? And then for those situations where we have the extended surge, where Children's and Cardinal Glennon and other pediatric facilities are saying, we're full up, no room in the inn, how are you going to deal with those kids that you were kind of stuck with? Especially if it's like COVID now, where you're already full of adults. How are you going to kind of accommodate that? So each of the components for the modules, we'll have a kind of just a situation update, some discussion, and then inside of your groups for each of your facilities, one person to just kind of act as your internal facilitator. You guys know your plans as well as anyone. So figure out what's going to work for you, talk it out so that you can kind of, when we get to the brief back portion, that you can highlight anything maybe you realize that others hadn't, or vice versa, and we can all grow and learn from this. We will kind of talk about some of the specific issues as they come up and try to, we won't solve the world's problems today, but we may come up with some potential solutions. Players and observers, we're going to kind of skip through a lot of this simply because this is all stuff we've all done these kind of tabletops in the past. This slide deck is just repurposed routinely. Normally we would have EMA and EMS, fire, law enforcement, all of those folks in one of these exercises. Because of the nature of this, having fire and law enforcement, there's not a whole lot that they're actually going to really do. EMS would play a role as far as the pediatric transports. The EMA, as we've come to find out during the days of COVID here, have been pretty integral in getting supplies. We have to filter our requests up through them. So we'll talk through some of that process. And yeah, we'll go over plans. We'll go over some of the assets that we have, the things that are available within the coalition or within the region that maybe they're not specifically coalition funded, but that are out there. Again, talk some of the objectives. So, the incident management, pediatrics, surge planning, what to start, when to start, that kind of thing. Again, that coordination between getting supplies requested if we know we're going to need them, or finding an alternate care site, or whatever the case may be, and then that information sharing, which is our public health component. Working with them to ensure that we are getting the right messaging out universally. For those that are looking to track what capabilities you're hitting, this is just kind of the overall. These are pulled from the various different matrix that are out there. So for the ASPR, for the HPP grant, we're going to hit 1, 2, 3, and 4. The FEP grant, those are the specifics for the capabilities that we're kind of targeting with this. And then for those on the EMS or emergency management side, the DHS. But so again, there is no wrong answer. Everything here is designed to just be discussion. There shouldn't be any major decisions, no huge muscle movements. It's just go through it, figure out in advance so that we don't have to try to figure it out as it's occurring. Again, if you have something that really necessitates a much deeper dive and conversation, then we'll make note and actually set up a working group to try to drive those issues and try to resolve them. So our assumptions and our artificialities. Obviously, when we first wrote this, things were different than they are now. To try to keep this in play as it's happening would be almost impossible, because as we see, things are changing by the hour when it comes to the COVID side of it. So if you wanted to substitute COVID for you pick it, any disease you can think of, that's effectively what we're trying to focus on. The scenario, obviously, I mean, it is plausible. It's happening in real time. There's no trick questions, no hidden agendas. Everything's pretty straightforward. You're all going to get the same information at the same time. It's going to be as simple as we can make it. What we want to answer as far as our overall real questions, what can we do as a region to be better prepared to support a surge? God help us that we lose our pediatric facilities and we are forced to deal with this at the local level. How are we going to do that? What are the resources that we best need to maintain? So whether it's PPE, pediatric size supplies, specific pieces of durable medical equipment, things of that nature. And then again, what training? We try throughout the coalition to try to bring in training as often as possible. We actually had a pediatric, rather ironic, honestly, a pediatric planning course scheduled back in March that was canceled because of COVID. That was designed to get us up to the exercise we were going to do with the ChemPAC and shortly thereafter. Unfortunately, that didn't happen. So we do have that back on the books again for, I believe it's March or April of next year. So we'll go into module 1. And again, this is just kind of like you're starting to gather your intelligence. You're getting information. So the scenario when we first drafted this, they hadn't said if schools were going to try to reopen or anything. We were just kind of looking at what they were saying might happen. So we'll go with the September date. Schools are back in session. They're giving us the standard. There's no more than 50 students in any one place with the daily screenings, all of the things that we kind of see happening right now, masks, hand hygiene, staggered schedules. So this is just to give you some situational awareness as far as what was coming out. At your facility, I would imagine that when we see this, especially for those that have children, you're automatically going to start thinking ahead, because parents tend to do that, at least in my experience. I'm not a parent, so I can't really comment to that component of it. Continuing a little later in that same month there of September, we're starting to look at, getting reports. National news is saying, hey, we're seeing an increase. We're seeing a lot more kids getting sick. We're seeing issues, higher acuity. As it says here, you're seeing an increase in ventilator-dependent patients at some of your pediatric specialty centers. We know there's a limited amount of space. If we start to see that surge and they don't have ICU space available, we're going to end up with some issues. So we get that message at 8 o'clock news. By 1 o'clock, we've got Greg and folks from IDPH saying, hey, we want to know twice a day reports, which typically what we would do in a surge is update twice a day what bed availability and things like that are. So this is kind of following along on that same notion. Now, when we originally looked at this, we thought the testing was going to go a little different than it did. And we thought there was going to be a little more testing capacity. So the idea of providing twice a day tests, that's kind of been mitigated now through other, well, not so much mitigated, but done through other means now. As we go on into the Monday, October the 5th, when we start to see additional notices coming from IDPH, whether it's through Siren or through email or whatever the case may be, the alert to say, hey, we're seeing these additional patients. They're seeing more, especially in the Chicagoland area where everyone's kind of stacked on top. When you're starting to see your pediatric facilities, filling up, They're telling you start getting ready. The hope is, and we've learned that this may or may not happen, that IDPH will be able to start distributing additional PPE like they did when we started to have our adult surge. Hopefully that'll still be an option if we do see a pediatric surge, because I can tell you that our pediatric supply list, as far as the region goes, is very small. We don't maintain a cache. Our PPE list right now for the region, the stockpile that we're sitting on is getting smaller every week, and we're not seeing any form of resupply. So when you're thinking about what are you going to need and when are you going to need it, it's order early and order often and hope that you can get it, because we're in that position right now. As far as a region, we're unable to get a lot of what we asked for. And if we can't get it, we can't give it to you. So factor that into your local ordering process. Continuing on, you start to get reports on Wednesday, October 7th there. Your ED, they come in and say, hey, we're seeing over a dozen pediatric patients with moderate or severe symptoms just in 24-hour period. Yeah, and this is, again, we're talking the schools still were technically supposed to be in session. Again, our real world situation is that may or may not happen. This may be that kids were just out playing, got sick, got together, whatever the case may be. But again, pediatric specialty hospitals are at surge. They're full. You start getting memos from them saying, we're only going to take the worst of the worst. We start seeing news reports again from across the state, same situation, ICUs at or near maximum across the country. We start seeing IDPH again putting out that enhanced reporting because they're going to want to know so that they can begin to factor and plan. Again, hopefully getting more supply coming in. When we get to your group discussion components of it, the things we want to look at, this is all still early on. We're still in the intelligence gathering component. We're seeing patients, but we're able to manage what we're seeing. But as you're seeing the patient increase, you need to be factoring in what you're going to do. So how's your HSO going to respond to the media inquiries? Because we know, especially if you're in a rural facility and you have a very limited capacity when it comes to pediatrics in general, it won't take much to overwhelm you. When the media starts popping in, asking questions, how are you going to react and respond to that when transfer outs are problems and things of that nature? If you do end up having to board a patient for an extended period of time, whether it's 12, 24, 36, 72, you pick it, how many hours you want to consider to be an extended period, are your staff really trained to accommodate that? Because the pediatric side of things, as far as pharmaceuticals and everything else, are a little different. Do you have enough of the necessary materials to accommodate that? How many pediatric patients can you hold in your facility for that period of time before you exhaust your supply? I can tell you, based on the conversations I've had here, we don't keep a huge stockpile. We do have, resources that we can get it from, our BJC cohorts across the river. But, if your facility is not tied to a larger entity, well, what is your backup plan? Again, going back to it, what's the resources within the region? So, and we're talking right at the moment, just pediatric. We'll imagine we're not seeing an adult surge. If we're seeing both, that's going to change the game significantly. And more than likely, if we're seeing one, we're going to see the other together. So if you would, just at your independent groups, kind of just go back to these questions here. Look over these questions. Discuss this amongst yourselves for a few minutes. I'd like to get an idea, kind of what your independent facility and agency plans are to kind of work with this. The Pediatric Surge Annex itself from the coalition, at this point in the game, we're primarily going to be at the RHCC level. We're going to be making requests to IDPH and IEMA, as well as any other source we can to try to secure resources, equipment, PPE, ventilators, things of that nature, whatever we can kind of get our grubby little mitts on. That's what we're going to be focusing on at that point. At the hospital level, we're going to be going through these same questions at the same time we're trying to do the RHCC, sourcings. So if you would go ahead and take just, we'll take just 5 or 7 minutes, kind of look over that, and then just discuss it as a group here, and then we'll move into the stage where we're actually starting to see those patients and how we're gonna how that's gonna look. If anyone has any questions, please do feel free to ask. I'm going to throw an extra bullet point into this that isn't on the slide deck, but something else to consider again is if you've got staff members who, obviously are parents and their child possibly becomes one of the sick, how many people can you expect to realistically lose from your staff due to that? And what's your contingency plan for that? We'll give it just a couple more minutes. All right. So since I know we've got a couple of groups on the phone, let's bounce over to Gateway to Rick and crew. Um, Rick, what were your guys' thoughts on this? What were your discussion points that you hit?
We were going to give you a call, Lee. That's what we were going to do. No, actually, we were sitting here talking how we thought right off the bat, Clay mentioned having a pediatric sustainability exercise to see what we have in the hospital that could maintain and sustain.
Okay.
We're also looking at, what trigger, using the annex, what trigger would we call a surge? And we're thinking that could be as low as three kids.
Yeah, absolutely. I mean, if it exceeds what your capability is at that time, that's a surge. I mean, there may be some days where one kid is a surge. Especially if it's one really, really sick kid and you have nowhere to send them.
Right.
What did you guys, when you talked about your staff training, do all your ED nurses and everyone go through like PALS and ACLS and all that? Do you do any additional training or anything beyond any of those?
You guys, I'm looking over here at my ER crew.
Well, respiratory, NRP.
Can you hear that?
Yeah, I can hear NRP. Yep.
Yeah, respiratory.
Every few months, it's just demonstrations, how to cry a kid, how to do a chest tube.
We do what? In-house staff training demonstrations.
Excellent.
And ACLS, you have ACLS too.
Right.
PALS, yeah.
Okay.
Does that answer? Sorry for
Absolutely.
all the dead air.
No, you're fine.
Probably talking to the least educated in the room, so.
So, Gary, over at St. Anthony's, what was your guys' take?
Hi, this is John. We said that if we had 1,000 pediatric patients, yes, indeed, that would put us into the surge capacity. As far as like handling the media, we would like to handle it and plan forward, looking back at how it was handled previously. And our staff trained, the ED staff is PALS, ACLS, TNCC, NRP practice, and Jumpstart trained. So, we have a lot of pediatric knowledge. Resources, that would be a problem because we have limited resources here for pediatrics.
Okay. Anybody have anything, any of the other hospitals, departments, agencies have any other talking point that you think would be pertinent to the group?
This is Eric. I'd just like to weigh in that my point of this, Lee, would be I think early on, with the news reports per your script starting on Friday, September 28th, and then the reported influx of patients by October 5th. I would think that a lot of us would probably at least have a fairly solid tentative plan in place, because I think that from the regional standpoint, we all know our weakness is actual pediatric resources. But the strength that helps to overcome that weakness is good communication and planning. And I would think with that much of a leeway, that this region would have a pretty solid thumb on what's going to happen before it happens.
I agree. And the part of the reason we had that kind of delay in there was because it's not really like a bus, plane, train crash that's suddenly overwhelming us. We figured it might ramp up. And again, when we originally built this, we didn't know kind of what was going to happen. This one's definitely, it didn't go the way we hoped. But I do appreciate the input, and it is something that I agree. I think that we would have a pretty good plan in place. Whether or not resources are available, I genuinely, it frightens me to say yes or no. I think that anything we see, we're going to have challenges, as we're finding just right now with the adult side of the world getting things. The pediatric component, I expect, will be equally as challenging. And I'm curious from I know based on an earlier conversation when we first started with COVID and the ventilators, how many of the hospitals that are on actually have a pediatric capable ventilator or ventilators?
Anderson does.
OSSC has, we have one. We have one.
Okay.
Okay.
This is Sue from Stockton. We have one.
This is Marcy from Fayette. We also have one.
So I'm hearing a trend of one. I have the feeling if we have two patients, we got a problem. So the other concern I have just is your ventilator that's pediatric capable, I'm assuming is also adult capable. And do you have a plan in place on what you're going to do if you already have a patient on said ventilator when child presents?
Go ahead.
St. Anthony's has the ability to rent vents through ministry, so we have available resources to replace it.
Okay.
Okay.
So I will throw out that we do have that cache of ventilators in the region right now, at least for another year until their calibration expires, because getting them calibrated is almost impossible. But we do have some vents that are here still that were purchased with grant funding. Some of the resource hospitals have some, but I believe they're probably out of cal right now, so they'd have to be recalibrated. The ones that we had from the state are all going back to the state. They're actually waiting for a pickup to be arranged now, just so everyone's aware.
Hey, Lee.
Yes, Greg.
I just wrote down a couple of things that I just throw out for everybody. So when I was looking at this, I was thinking of, cross-trained staff or developing just-in-time training on some of the basics of caring for pediatric patients. I was thinking about pediatric admission policies because from what I've learned through our latest round of EMSC, that pediatric patients can be admitted even if you don't have licensed beds. And my assumption is your EDs are going to be full and can't be housing pediatric patients. They need to get them out of there so they can be taking care of other people. And in those pediatric admission policies, where are you going to put these patients? How are you going to make sure, because they're pediatrics, that they're secured? Those kinds of policy decisions ahead of time might help when you're under pressure, kind of thing. So those were my thoughts.
That's a very good point, Greg. For anyone that didn't know, Greg was here doing.
Yeah, I was also going to say, I also noticed that a lot of the hospitals have pediatric physicians in their EDs that could be part of that admission and care process if you did have to admit the patients for 72 hours or something like that.
That's a good catch, Greg. Yeah, Greg was here yesterday doing the EDAP for our two campuses, and when it wasn't here, but he was here virtually. We had that some of that same conversation yesterday. I appreciate you bringing that back up. So what we'll do then, we'll go ahead and set into module 2, which is effectively the surge itself. So again, timeline's a little wonky because, again, we weren't sure what was going to happen. Tuesday, 13 October, We're seeing, in your emergency department, your admin folks are telling you that you're now holding 3 peds patients and waiting for, a slot to move them to. Both Glenn and Children's, they're telling you that they can only take the absolute worst case. Anything else you're going to have to sit on. They just don't have the space available. At the same time, you're seeing that surge of adults, with 3 out of the 7 having to be admitted to ICU for additional critical care support. How's that going to play into, I know St. Anthony said they can secure additional ventilators and things of that nature. How quickly can we source those items? I know there was up north, there was a big surge when this all happened early on, looking for those vents. Admittedly, that was before, the clinical side had said that vents weren't necessarily the best option. But with the way we're trending now, is that a realistic expectation? Would you start ordering those vents as soon as you saw the news releases and the potential spike from IDPH? Or are you going to be waiting until, okay, now we know we're going to need it? I know there's costs associated with the rentals and sitting on them, but at the same time, things like that to be considered. Trying to get my slide to advance here. Here we go. So this module's quite literally fairly short here. So when we start talking about, let me make sure that skipped right. It did. Okay. The key issues from this. So you're boarding these patients. You're now holding them for an undetermined period of time until that specialty care facility can accept them. You're also seeing that increase in the adult side. So you're seeing that double whammy. What are your facilities' plans in terms of pediatric diet? The other issues that go along with holding on to kids. Do you have information for that already existing inside of a plan inside your facility? I will point out we do have in our coalition plan and the actual pediatric surge annex in Appendix 3, there is a dietary needs of children section that we very blatantly took from our fine friends up in Chicagoland out of some documents that they provided us. If you don't have something already pen and ink on, on a document in your facility, this might serve as a good starting point for you. It kind of helps to identify things and break it down, especially things that don't necessarily need to be, heated up, stuff that's readily and easy. I encourage you to take a look at that and consider that, because when I had a conversation with it was someone from our BJC children's side that mentioned the pediatric, I don't have kids, so I don't know this. Apparently they don't like to eat the same thing adults eat. Planning ahead for that contingency. So again, if you're sitting on them, what are you going to be thinking at this point? What is your plan? What are you looking at? We've tripped triggers, obviously. We're now into the uh-oh stage, and things aren't going the way we wanted. Anyone have any thought on this?
Lee, this is Eric. I think we would want to consider doing family assistance, family information centers. Because if we're keeping kids, which most of us don't, that's going to be an interesting situation, especially if we're talking about it still being in the midst of COVID, when we have already ongoing pretty staunch visitor restrictions. It might be difficult to tell a family that they can't be here with their child, especially at a facility that is not known for pediatrics to begin with. So that's just something else to toss on top of the things to think about.
No, that's a very good point. To that point, I would think that the facilities probably, as part of like your pediatric reunification, you've probably got those kind of areas identified in your facilities. Given the current limitations on visitors and keeping people, if you will, out of the house, how is that going to affect those facilities? Do you have another area that isn't necessarily inside of your campus that you could set up for that? Would this be an option for like a partnership with, whether it's a local church, school, Red Cross? I mean, is this something we need to, as a region, maybe pursue further and try to come up with a region-wide guide for this, or?
This is Gary at St. Anthony's. I think that would be, if we can come together, maybe have a committee on coming up with a region guide. I think that would be a great idea.
Okay.
Lee, this is Brad at St. Elizabeth. I think a lot of that would have to do with your resources, because we do have something established simply because we have urgent cares. And we have one right across the street. So the physical layout of our resources, and plus a church across the street, are both of them are part of our plan. So it would have to be dependent upon your physical limitations that you have immediately to you, where some of what we have available would not be available for other facilities.
Yeah, agreed. We're in the same boat. We've got churches directly across from both campuses that we have MOUs with to be able to do that. And I think that may be something that we look at is, coming up with some kind of a planning guide, not a region plan where we're telling you to do something, but helpful, here's resources and kind of be able to help support with that. So Scott, I know you're on. That may be something we task you with next month when you're in the office for your week. We'll discuss that offline and figure that out.
Lee, and also I wanted to mention, when you get back to your food situation too, we just went through our EDAP, which is a great thing to go through and have this following within a couple of weeks afterwards. But when we started thinking about our food resources, we outsource all of our fans. And so they have much deeper resources than we would as a facility. So when we met with our fans director here and talked to them about our pediatric capabilities, they had a complete plan already written and turned around and printed it and handed it to us. So having that resource is a great thing.
I agree. I think, and we're in the same boat. We outsource for our dietary here as well. And the same thing, when I went down and asked Stacy, we did this a while back. She actually was able to give us a plan. And I mean, for some of the smaller facilities that don't have that option, I mean, like I said, there is some guidance that's in there that might help. Again, we're not telling you what to do. We're just trying to provide you the support to be able to make those decisions and do those things and make it as easy on you as possible. What we'll do is we're going to go ahead and continue on here, continue the discussion component of it. So, going back to the information we got from the early on here in this second module here, the additional requirements. We've already kind of talked about some of the things, some of the critical issues and the decisions, but as we start talking about general subjects that we really are going to need to figure out, things we're going to do going forward. So we'll work on that guideline. We'll start looking at, I liked the idea of some of the training component ideas. And it may be something we try to bring in some outside support for. We can do that with the grant, try to get some additional training. And from a nursing perspective, if we have a nurse on who can tell me for sure if there is or isn't, I know we have TNCC, I know we have all of that. Are there any pediatric specific courses that might be something we could potentially look at doing along that line? Eric, ideas?
Why are you picking on me, Lee?
You're my favorite. What can I say?
You guys you hosted a great pediatric planning class a couple of years back over there, and I think it was in Waterloo, or was it where was that? Columbia. That was awesome.
And
I
that's
went.
actually that's coming back next year.
That was fantastic, especially from a disaster planning type of thing, and it fit really well with the survey that we had from EMSC that Brad just referred to. There's a lot of pediatric classes that are available that are, and I sound like Gateway is hitting on a lot of those as far as the care portion. The difficulty that both hospitals have is, I know it took me a long time to wrap my head around basically what you're admitting all the time, Lee, and that's the fact that kids are different, and I have kids, and it's still different when you're planning for a disaster surge. The best benefit I had for planning for pediatrics was living through H1N1, and I'm sure our friends across the river can talk to that. With like I remember Children's Hospital having triage tents in their garage. That hit the pediatric population really hard. So that's why I saw this exercise you set up, and I dusted off my old response from H1N1, and a lot of it is a good effective plug and play. So yeah, I'm glad you're bringing back that I think it was a FEMA-based class, wasn't it, for the pediatric?
It's actually a TEACS course from Texas A&M. And I actually was just talking to my guy a week and a half ago, actually, scheduling for the spring. We've got 2 dates they're working on trying to slot in for us. I believe it's one's the end of March and the other's beginning of April.
Hey, is that the course that was scheduled for March?
Correct.
That looked like a good course. I read up on that. I was really looking forward to it. So we're kind of excited to attend that course when you have it next year.
Yeah, it's an excellent course. They do a great deal of very useful information, and they've updated it since I took it with Eric. Actually, they've updated it since then. So I'm eager to see what revisions have been made. But I will, as soon as we get that date actually fully inked, because right now they still can't permanently book a date until their COVID situation is released, because they're on a restriction. But we're penciled in. We have 2 dates. They're just waiting to figure out which one it'll be. And then we'll put that out to the whole region. Now, again, going back to the training options, though, we've talked about the planning training. Are there any clinical-based training courses that might be worth bringing into the region to help prepare not just ED, but clinical floor staff and such? Like Greg alluded to, we may have to actually admit pediatrics at some point. Is there something we could potentially look at doing, like we do with the TNCC, that would help bring that PEDS level up for the regular nurses that might be caring for this patient?
This is Sue from Staunton. Right in line with TNCC is the ENPC course that's specific for pediatrics, but I feel like in the event that we would have to house these kids and care for these kids here, again, in facilities that aren't generally taking care of those kids, one of my biggest concerns would be not only supplies and food and diapers and all that, but the medication administration is always such a difference, between adults and children. And if you're not used to those medication differences, and dosing and administration, big mistakes can be made. If there was any sort of education module or training that could follow suit with pediatric medication administration, I feel like that would be a good, identified need.
Okay. That's a good point that I will talk it. Danielle, are you on the line? Rick, is Danielle with you?
So she's right here. Hold on, Lee.
I'm sorry, I missed the question.
So you are a pharmacist, are you not?
That's correct.
See that bus coming? So
Am I under oath right now?
No, the question that Sue just posed, as far as like some training for pediatric dosing and administration, you think there's something we could, from a regional perspective, kind of help to do, or is there some coursing that we could bring in that would help? I mean, this is kind of in your swim lane, as they like to say.
I wonder if there'd be some outreach from some of the bigger hospitals in St. Louis, if they have any sort of education department that they would be willing to send someone over for. Personally, here at the hospital, we do modules from ASHP, which is Health System Pharmacy, just to kind of know the delivery devices and the volumes that you need to use, and keep that familiarity. But as far as face-to-face, I think that's most effective.
Okay.
Like, to bring someone in would be most effective if we're going to have a regional resource.
Okay. So Sean, if you're still on the line, I might reach out to you to get some contacts, and I know you've got those on that side of the river.
Sure, we'll be glad to collaborate with you guys. Lee, I've got a question for the group. Do you, as far as pediatric surgeries go, is there a weight limit or an age limit at your hospitals for, like, let's say a 13-year-old comes in with an appy, needs an appendectomy? Are they automatically transferred, or is there an age limit or weight limit?
That's a great question. I don't know the answer to that for here.
What age? 300 pounds or up? But what age?
And height and weight. So if they meet like an adult height and weight criteria or body mass index, then usually our anesthesia is comfortable.
Yep.
That's how we do it. And yeah, that's our policy too.
Yeah, I mean, at least on the St. Louis side, outside of pandemic prep planning, just for like MCI, we've talked about sending, the teenagers to non-pediatric facilities if we had like the Joplin tornado or a mass shooting, just to unload the pediatric facilities. And when you got 16-year-old boys out there with a full beard that weigh 200 pounds, so they're basically an adult.
That's a really good question, Sean. I'm making a note of that. I'm gonna follow back around on that, and we may send out a survey to all of the hospitals just to get an idea on how people deal with that, because that's, like the earthquake scenario. If we lose the bridges and we can't send people across, what are we gonna do? And that would actually be a good way to look at that, I guess. All right, so a couple of questions that are sort of specific to departments going forward here. Excuse me. With the emergency departments, we already talked a bit about having, like Greg said, a pre-plan for admission. Do you have it, or are you gonna have to hold them in your emergency department? And what supplies do you expect would be the greatest need? Now, we're thinking sick kids, not plane crash, not bus, but sick kids. What can we do in order to decrease the chaos and gain control? Because I would imagine, like was said, if you've got like Eric said earlier, if you've got kids in the hospital, limited visitation, you got the whole family wants to get in and see the kid because the kid's really sick. How are we going to deal with that? And like I know Jim from our security is on. I know Gary's on from St. Anthony's. I mean, these are considerations that I think you guys would have a pretty good say in. The transfer agreements. Again, assuming whether it's maybe it's the Great Quake and we can't go west. Do the facilities in the region have other agreements to send, whether it's north or east, to go to any of the other, like Riley and Indianapolis, or up to, Bloomington, I think or Springfield, I guess, has a pediatric unit. That type of situation. Do we have those in place? Do we know what we've got to do if we need to activate those? Again, looking at that whole from a staff sufficiency, do we have not just the right number of people, but do the people have the right credentials, if you will? And if not, how do we call it in? I'll give you an example, going kind of a little bit away from the sick side, back to the injured side. We did a MCI exercise in November And one of the key takeaways that we had from that exercise, because we mixed in pediatrics pretty heavily with our adult, was our sole pediatrician who's in the ED became very overwhelmed because due to the way our patient records is and everything like that, non-ED physicians could not discharge an ED patient. It had to be done by an ED physician. So, he's trying to see kids that need to be seen and kids that don't need necessarily to be seen, but they can't discharge them through anesthesia or whoever. It became an issue. His question was, can we call in? You got pediatricians in your local community. Do you have an agreement with them? Maybe they don't actually have the privilege at your facility. How long would it take you to get them spun up so they could come in and maybe see patients in the hospital? Again, you don't admit them, so they're not normally seeing patients on the floor. What could we do to make that happen? Going back to the ICU side of it, if you are having to intubate and ventilate on a little one, how's that going to play? Are they going to be comfortable with it? I know it's not something. Again, a lot of the facilities don't have a whole lot of capability when it comes to ventilators. So those kind of considerations, and then so the first 6, we kind of talked about those. What other action items are you going to be looking at from an emergency department? So the first line of defense here, what are you going to be looking at? What are things that, maybe Gateway sees that Anderson didn't, or vice versa? Anyone?
This is Sue from Staunton. As far as number 3, the waiting room, we would probably start segregating waiting room space, utilizing adjoining areas of open dead space for waiting spaces, cordon off to try to control crowd, and then bring in staff to help, maintain crowd control. As far as transfer agreements, do we need transfer agreements if we're trying to call out farther than our region or our neighbors? Just like that burn surge annex for the state, they don't require additional transfer agreements. If we start spiraling out, crossing over into Indiana and up, towards Chicago and Iowa, we don't have to have additional transfer agreements with those facilities. We're just spiraling out just the same way we do with our mental health right now. When we can't find a bed nearby, we start going out from there. And, those written agreements aren't required for that type of situation, I don't think.
Okay, I'm really not sure on that. My understanding was if you had an agreement, it was kind of like a little higher precedent, or, like preference points. But again, not really sure. That's kind of the reason we ask that, so that we can get an understanding of what the expectation is. Greg, you have any input on that? Any idea?
Well, I know that transfer agreements are part of the EDAP and CDAP process. It's also part of the trauma process, all of those kinds of things. But those are all parts of those programs. What is actually in regulation as opposed to those certification programs, I honestly have to say, I don't know.
Okay, that's kind of where I was coming from, because I went based off of EDAP, because we were spinning up for that when we were building this.
Right. I tend to believe Sue, because, people do have to get transferred to specialty hospitals way, way far away, that in those types of situations, those extenuating circumstances, a transfer agreement isn't necessarily a requirement.
Okay. Anyone have anything else regarding any of the action items, things that you might expect or might not expect for that matter?
Lee, this is Sue again. I'm sorry, but I got a question. One of the things we would do to help assist with these kiddos is bring in those volunteer sitters. Um, I know your pediatric annex has a lot of resources on how to check rooms and your dietary lists and all of that, but I'm thinking it might be a good idea to have some sort of handout, little ditty that you can hand those volunteers when they're coming in. Okay, now you're going to be sitting in the lobby with all these kids, and these are some of the key points you need to think about because they're kids. I don't have anything like that specific for my volunteers, and I feel like that might be a good resource, a good tool to have in my, my toolbox.
Okay, nope, I can see where you're coming from there. Now I want to ask a question because the word volunteer always makes my skin crawl. Are these just-in-time volunteers, or are you using already pre-credentialed and vetted staff, like volunteer staff, if you will?
Well, volunteer staff would be utilized for actual clinical care, but to sit a room, to sit the lobby, to sit outside a cohorted area to prevent leaking of children, that kind of thing. That could be just in time volunteers. Our community is small, and our clinical staff is even smaller. So if we need to corral the kids, we'd take the ladies from the church. But I feel like a little handout would be nice for them.
Okay, and the reason I'm asking that is just as far as what the whether you're background checking anybody or anything like that, because we do have some links in the plan for where you can, just some suggestions on ways to rapidly check people to make sure they're not actually on that list. But I'm making a note to the one sheet that you requested here, the basically like a front and back one sheet of useful information. Okay, so general hospital response, not just the ED, but kind of the whole house, as it were. Your hospital's pediatric surge capacity, what do you have? I mean, what if you were to have to admit, and again, remember, we're talking COVID right now. So we're talking, you're seeing possibly a higher number of adults, not just children. Do you have areas that you could set up as, lack of a better term, pediatric ward? Is there an area that, you would be able to do that? At the same point, when are you going to start looking at trying to unload, offloading patients to other facilities? Maybe you have to transfer the adult to make room for the kid, things of that nature. And then again, when we talked, like I alluded to earlier from our exercise this last go around, identifying and notifying providers that may have that clinical expertise that you need. If you have pediatricians that are in your community that maybe they don't practice in your facility routinely, have you reached out and discussed with them, hey, in event of XYZ, can you call them and will they come? Again, finding those folks who maybe within your own staff who previously worked with pediatrics, who may be able to help with like a pediatric specialist team that you can, maybe they're not practicing pediatrics now, but they may be able to fall back on knowledge learned previously to step up and kind of help and specialize in that area. And we already talked a bit about the pediatric equipment and drug dosing guidelines and things of that nature. And I think that's definitely something we're going to have to look at, because I like that idea that you brought up, Sue, about the dosing and administration training, and with the information that Danielle brought up. I think there's some option there that we really need to look at from the coalition level. And then when we go to the communications component of it, like I said a few minutes ago, if you have to transfer out an adult to make room for a peds, where would you expect to send? How would you expect to send? What equipment could you borrow? Whether you're borrowing it from, maybe you're borrowing from us, or maybe you're borrowing it from St. E's. Do you have an idea of what kind of, again, going back to that, what can we try to cash that may be needed? And again, looking at staffing, we know that's going to be a problem just in daily operation. I imagine if there's a lot of sick kids, it's going to be an even bigger issue because parents are going to want to be with the sick kid. So I'm open to hear any input anyone has, any way we can try, anything we can do, whether it's from the region perspective or even just from an independent facility perspective to try to accommodate some of this. Anyone? Okay, well, we can come back to that. Don't forget. So the administration side of it, solely because at this point we know we're going to be definitely seeing media, because you're going to have some parent who gets completely torqued that they're not able to get in with their child. Somebody's going to want to make some kind of a public statement. Someone from the hospital is going to have to make a public statement to try to calm it down. And this just goes into just in general. Do you already have your public relations strategy predefined? Who's going to speak, what they're going to speak, where they're going to speak? Do you have a nice, clean, white jacket and stethoscope hanging for whoever's going to be your mouthpiece to look the part and fit the role? That type of thing. At that same point, how are you going to determine what specific information you say, what you release? Is this something that's going to be, or should this be collaborative with your regional public health, not just your local county or city, but the whole kit and caboodle? My perspective is I think we need a unified message anytime we talk to try to keep confusion to a minimum. Also, how's your hospital command system, your hospital command center here going to look? Are you actually going to be running your little command post all the time? I know when we first started with COVID, we were running 12 plus hour shifts, and we had leadership in the room, and we were working issues as they occurred. Is this the type of situation you're going to be doing that? Are you going to have a pediatric specialist in that little group? How are you planning to do that? Are you going to use some virtual means? And if you're going to do a virtual, do you already have an agreement with maybe someone at one of the pediatric specialty centers that could speak in that scenario, in that setting? And then again, going back to that whole regional PIO, their local PIOs and things of that nature. So I'd like to hear some input. What do you see from this perspective? Because I know we have a lot of folks who, like me, we're not really clinical. This is the part we get pulled into. What are we thinking? And from the local health departments, I'm really interested to know what your take is when we start talking about saying things.
So here, this Phil, let me jump in just quickly on this point. One thing that I'd like to commend our brothers and sisters on the west side of the river, in the St. Louis area, for doing is, they put together their COVID. They put together a few task force, but one specifically being, and Sean, correct me if I'm wrong, I don't want to call it the physicians, the physicians group, the task force, but of your task force, of the major hospitals, SSM, BJC, et cetera, that were over there, you guys were working together to come on, you're still giving briefings, et cetera. But you guys are working together to kind of have a consolidated message with regard to how things are going in the St. Louis metropolitan area, not specifically Metro East, but metropolitan area. given our demographics and our geography on this side of the river, that's always been a challenge for us. You guys are again close knit in this, and if not just for the sheer fact of how close all of the hospitals are from one another, um, but you guys share a lot of the exact same resources, a lot of the same surgeons, a lot of the same physicians travel back and forth between those hospitals. Outside of, let's say, for Memorial Regional Health Services here in the East, we may share some physicians that are between St. E's and here. Those type of things are a bit more disparate than they are on the west side of the river. So could you talk to Sean, could you kind of just put some of that in perspective of what you guys are doing today and maybe how we could leverage that in a pediatric emergency dealing with the exact same disease, dealing exactly the same with COVID, how you guys did that over there, and maybe we could try to take some or glean some best practices or something off of that to implement on this side, because I think Lee and Sue and as folks have been talking, that information congealment and togetherness with regard to patient care is one of the things that we are devoid of to a certain degree here in the coalition, and primarily because of our geography, because we had to go, we start from here to go all the way out to east to Fayette out of Vandalia. It is a trek, and it's a little harder to do that on this side. So Sean, would you mind just talking to that just a little bit?
Sure, Phil. Well, let me start by saying that in a way we're fortunate that we've got three large healthcare systems, because it makes a lot easier for everybody to buy in. But early on, our CEOs and CMOs got together with our local government officials, and so that made it pretty easy. And basically, John O'Brien from SSM and Andrew Blevins from Mercy, we basically had a 10:30 call every morning with all the nuances of the response. And finally, the light bulb went on, and I said, well, what, instead of us playing matchmaker, let's get all of these experts on an Excel spreadsheet to talk to each other. So that's when we joined our computer documentation folks for all of your clinical documentation. Again, we're fortunate in St. Louis that we all use Epic. So we tied all of our Epic people together, all of our lab people together, anybody that was standing up a specimen collection site to share those best practices. So then that allowed the three of us to go out to the St. Louis County EOC to look at true regional planning. So as you saw, we stood up a decedent center, basically, if we would have got what we thought we were going to get. And then the alternate care site at the hotel. So that was, and along with that, there's an EMS component, an emergency management component, and obviously coordinating with your public health stakeholders. So Phil, when we went out to the St. Louis County EOC as part of the pandemic task force, the task force is, made up of the systems, but we, as you're aware, and you mentioned the MAC, we're just part of the multi-agency coordination. So although the hospitals, it seems like we're somewhat in the spotlight with Dr. Garza and the CMOs leading the charge, we're just a spoke in that wheel. So it's truly the government officials, which I learned the hard way. When you look at those boundaries on a map, especially when it comes to public health, they truly are boundaries and they're actual barriers. So number one, I would recommend with all your various counties out there to try to encourage them to share best practices like the hospitals do, with the planning and the collaboration that you guys do for the Hope Coalition. As far as the PIO, again, I think you're a little different because we have the three large systems. So right away, I think we ran an ad for 6 straight weeks in the St. Louis Post-Dispatch for all of our trademarks were in the paper for St. Luke's, BJC, Mercy, and SSM. So yeah, to your point, Phil, the messaging from day one has been very collaborative in that, the youth sports guidance, trying to bring youth sports back. We've been working on, it's been more of a struggle with school reopening, engaging the schools, but I think we have that now. So anything from testing capacity to visitation policies, we've shared all of that together. And I hope that answers your question. Was there anything specific that I missed?
Not at all. No. I really appreciate, you providing a little bit of that perspective for this group again, because, we have a lot of hospitals, and those hospitals again are not, and a stone's throw from each other, with the primary exception of us, St. Elizabeth's, and, Gateway probably being the next, and Anderson, being, our closest folks that are here in the Metro East. So, I mean, it's good to hear that, because I think that is when we go back, when we look a year from now, 2 years from now, I think that's a success story for the St. Louis area. And on our side, I think that there are still some areas that we can gain, some traction on, and make things a little more cohesive in this regard. Because as of right now, to be quite honest, we're not fully stovepipe, because I think we have a lot of good guidance that is out there, and IDPH, I think, has done a really good job of trying to get us all operating off the same sheet of music. So we haven't had to leverage all of what you guys had to initially. But I do think that as this scenario is playing out that we're going through right now in this exercise or this tabletop, we look forward 3 months from now when we're at, when flu season is hitting, school is in, I don't want to say full swing, but school has been going on for quite some time. We may need to operate more in that fashion. And I don't know if we do that from the resource hospital standpoint as we're kind of set up now. Our resource hospitals being kind of like the leads of the task force, and to help propagate that information and then bringing in our public health partners to assist with that. But I'm trying to see, how we can implement something similar that works for us, that is not seemed as burdensome or another meeting, but can actually provide tangible, supportive actions in response to the current crisis, in this case, pediatric, a lot of kids with COVID and no place to put them. So, I just looking at those questions here kind of gave me some of that there. I do know one of the questions that I did want to try to get some answer for. Lee posed it earlier, and there was a staffing concern question, and I'll use this for our hospital administrators. Again, Lee pointed out, and we all know healthcare is 90% are female. 90% of our staff members across the healthcare spectrum and hospitals are female. So somewhere between 88 and 91%, depending on what year you ask the Bureau of Labor Statistics. So what are we really doing at this point when kids are becoming sick, parents are now dealing with sick, and a personal note for me, I just found out my nephew, he's 9 years old. He just tested positive for COVID down in Savannah, Georgia. So what are we doing now that we have maybe a lot of moms? I don't know if we have a census on how many moms we have in the hospitals, but I'd say we have a fair amount. What are our staff expectations? I think that's maybe the best question. And I'm going to toss it up to the good folks at St. Anthony's. What are your expectations for staff and making childcare arrangements and/or taking care of staff? How do you balance that? And is there a trigger point to where, is there a break point and then you have to start going on diversion and denying all transfers, et cetera, et cetera? What does that look like for you guys?
This is Tracy from St. Anthony's, the ER manager. OSF recently sent out a survey actually to all of our mission partners, asking kind of what their status is with childcare, to kind of get a idea of what we're looking at. I know as managers, if staff has come to us with issues with childcare, we've tried to accommodate schedule changes as best as we can. So we are already looking at that at a ministry level to kind of prepare for the future.
Okay, and to that point, so we start looking at child care, but what about the inverse of where the staff has to take care of the child, or you know what I'm saying? So mom can't come to work now because son or daughter is sick.
Well, we try to fill the gaps as we can internally. Lucky for us, we do have other hospitals that we can, we have a CRT pool that we can reach out to in our ministry to see if they can fill some of the staffing gaps. Anybody else?
How about the redistribution of labor pool?
Yeah, we have, actually when COVID first hit, some of our surgery staff and GI staff, we cross-train them in different areas of the hospital to help fill any types of staffing gaps that we had.
Okay, thanks, Lee. I'm gonna turn it back over to you. Lee, did you catch that? I turned it back over to you. Not sure if you guys are still.
Ask that stupid mute button. We don't get along. So I want to take that question that you just asked, Phil, and I want to redirect that towards Fayette and Staunton, because they're smaller, further out, and I don't know if they would have that same option to pull in from other ministries like what OSF and what they can do. Sue or Marcy, right?
This is Sue from Staunton. We would not have access to much extra staff. I would assume that if we were in this situation, Anderson would also be in this situation, and they would be, as our sister hospital, our only other resource for extra staffing. We would take care of the cases that we had until we could no longer, and then we would have to go on diversion. The access to extra staffing is nil here. Agency always throws in their 2 cents, a month after an issue happens and says they have staffing to assist, but that's always a sticky wicket to bring agency in to assist. I know that we have agreements within our region that we could ask for assistance staffing in an urgent situation, but would that agreement that we have for our regional MOU apply to an ongoing long-term event like this? That would be my question. Otherwise, we'd have to shut down after a while. We can only do so much with so many people.
And that's why I picked on you, Sue. I had a feeling you would ask that question, and I was hoping someone would. Because I don't know the answer, but I think that's a question that we really do need to look at. Because, like you said, I mean, there comes a point where you're maxed out.
Lee?
Yeah, Greg.
So I just did want to go back to Illinois Help, which 43,000 people signed up for Illinois Help since COVID has started. But what we have found out from literally all of the hospitals, nobody wants a volunteer unless they happen to be a retiree from that particular hospital. I mean, literally. Some hospitals were desperate for help. They absolutely refused to take volunteers. So I don't know if moving forward, that's something that each hospital administration wants to look at to see if something can be streamlined to accept those volunteers. But it was just amazing how desperate some of the places were, but absolutely refused to take anybody who had not somehow been affiliated with that facility prior.
That's good information. I think I had heard that during one of the, maybe it was on an RHCC call, someone mentioned that. And I agree. I mean, the whole IL Helps program, the idea is great. I think we just need to get everybody on board with it.
Lee, this is Dale Stars.
Hey, Stars.
To the gentleman's point that several years ago, we had a pediatric exercise in the region. I think SSM had a full workshop kind of a day about it. And during that, one of the breakouts I was facilitating it was mostly nurses, and we were talking about some disaster planning and things. And I mentioned the statewide mutual aid that provided for access to doctors and help, workers from all hospitals to support workers in all hospitals. And there was a gasp in the room, and there was a large murmur that basically said the exact same thing that he said is, look, if you're not affiliated with a hospital, things are different, and you're going to cause more problems than what you're going to help. So we feel that some conversations in our region have really led to trauma might be about the one place that it might be the easiest, but once you get outside of a trauma room, then it becomes much more challenging, and ongoing care is also challenging because the procedures and everything is somewhat different from that. So, and that kind of goes into backing up a little bit further from that is that St. Louis hospitals had a mutual aid agreement as a region, which ultimately led to a statewide mutual aid agreement that MOU that's available and activated currently. But MHA, Missouri Hospital Association, sort of really oversees that. But any hospital can make the request and activate. So, from a regional perspective, to move to a state program, we have some precedent in our region with that, and we can certainly put you in touch with some other folks. But we've run into the same issue with people. Sean, feel free to jump onto that if you want to.
Yeah, just real quick, that's a great point, Dale. I can speak to the response in Joplin. MHA did reach out to BJC, and we ended up sending, I believe it was about 24 nurses down to Joplin over a 2-week period. And that was, we had utilized the Missouri Hospital Association MOU that covers that. So yeah, I would encourage use of that if you've got one at the Illinois state level. And I mean, hey, Phil, Lee, and the whole team, this is great conversation, and it just opens my eyes that I think Dale and I in our region over here, I think we need to collaborate a little more closely on the pediatric side to figure out how we could support. Obviously, BJC is going to support Memorial, but collaboratively, especially with, I think, help me out, Dale, Madison, Monroe, St. Clair, that's part of our UASI region for the St. Louis metro area. So I think between Mercy Peds and Glennon and Children's, hopefully we could help, with some SMEs or something, but I can't volunteer anybody. This is great discussion though.
Well, thanks. I mean, and that's kind of the goal. And yeah, we will definitely be following up on more further collaboration to try to identify and address some of these other concerns. So what we'll do is in the fact we're running out of time here, we'll go ahead and move on to the part that's going to take time, which is that extended surge response. All right, so now we're all the way into April. Now, this situation hasn't gotten any better. It's just gotten worse. And the date's wrong, so I apologize. I tell you what, I manage to miss things every day. But anyway, so we're looking at it. Your facility's facing challenges with boarding pediatric patients. You're waiting for bed assignments. It's taking longer and longer to get people out. And the federal government has said, hey, we're going to open another McCormick place specifically for, COVID patients, the ability to handle pediatrics, things of that nature. And as we saw before, you're going to get that request. And I know some, as I understand it from some of our conversations with other facilities, they suffered when McCormick opened because they were offering staff more pay to work there than they were to work at their regular job. How is that type of situation where the state says, hey, we want to open it here, we're going to need help? What would your facilities be able to provide? I mean, it's staffing, resources, even the SMEs, your subject matter experts, things of that nature. This is, unfortunately, I think, an all too real possibility if we start to really see this, that, we're going to get these kind of questions. We're going to have that need to open up those extra facilities. How would we be able to accommodate it? And Greg, if you can elaborate a little on McCormick, the physicians that were there, were those from HHS? Were those from hospitals? How were those people brought in?
Which facility? I'm sorry.
So for like McCormick, the large scale field hospitals that were set, were the physicians provided as a part of that package? Were those brought in as, were they from HHS, or are they, where did they come from?
Well, when they first set them up, I think that they were kind of the strike teams. But then when they started handing things back to the state, they came from all areas. So the state also hired physician and nursing from agency type staff, and up until recently, they were still using agency staffing for some of the local health department and stuff. Now McCormick has shut down, and Metro South or whatever is what's been stood up. But from what I understand, most of that is not volunteer, agency staffing, and then the people who are actually in charge were assigned by IDPH from a group that volunteered to do that.
Okay. So again, looking at the facilities and looking at things from a local perspective, if they said, okay, we're going to have to set something up, we'll use Collinsville at the convention center. They set up a field hospital in the convention center and they reach out. You may lose staff to that as opposed to taking care of a sick kid, because it may pay better. I just want facilities to think about how would, what's your policy on that? If they leave and they try to come back, are you going to take them? That kind of thing.
Yeah, we'd take them in a heartbeat.
Well, I mean, some places.
So that actually happened in Chicago. So they were offering, also they were hiring paramedics at, I believe, $50 an hour. And providers were complaining to the state about that. There was a big brouhaha, and because it really didn't affect down here, I didn't pay a lot of attention, but there was a lot of pushback at the state, to the state, from hospitals and providers because they were paying so much higher than the prevailing wage.
And that's where I was going with that, Greg, because we did have that conversation with some folks, and they were paying way better to go up there. Yeah, it's higher risk, but much higher reward financially. So, think about if you start losing people to that. I mean, are you able to incentivize them to not leave, to try to, or, shame them into not leaving, however you do it, just consideration, because we did see that actually happen. We heard a good bit about that from the folks up north, the EMS side especially. So again, key issues when we look at this, again, we're back to that whole, we're still holding people. We're holding them for longer periods of time because the situation has just continued and space hasn't. As alternate care sites are being discussed, are you going to just, first of all, are you going to outsource all your pediatric patients to the alternate care sites? assuming that they'll take it, or are you going to outsource all of your adults to the alternate care sites and keep the pediatrics because maybe the ACS won't take them? How would that affect your planning going forward, knowing that, again, the resources used to care for an adult are different than those to use to care for a child, and the additional draw on resources that's going to occur if they stand up one of these ACSs. So these are things I want you to consider. Try to look at it. It could happen. It's not unrealistic. And I worry, going back to the EMS side, I worry because I know if you offer some of our guys $50 an hour, they'll be there in a heartbeat. Yeah, and I know nursing staff, they were paying pretty well for that too. So, I mean, it could be a detriment to us to have that resource brought in to help us. So again, the items that we just looked at, what we talked about, we're just going to kind of go into a couple of specific questions. We'll start again with the emergency department. At this stage in the game, you've been holding kids for a while. Hopefully maybe you've got a process in place. What would you think, again, given the long duration, would be your greatest resource need? What do you think is going to be the thing that is you're holding them for more than just a couple of days, or you're holding a lot of them? Things that we can, again, as a region, using this amount of grant money that we get, which is fairly significant right now, to better prepare for this type of a eventuality. And that also goes for training. If there's any, again, specific training like we talked about earlier, we want to make sure we capture all of that. Anyone?
We're thinking.
And to throw this at the local health department folks, this crosses over to y'all as well. You're going to have a role in this. If there's things that you can think of that would allow you to, be of a benefit, or things that would help to, whatever the case may be, please jump in there. This is the quietest Tiffany's ever been. I know it's got to be killing her.
Do they make pediatric MREs?
I don't know. I mean, MREs tend to look like they came out of a pediatric. But I think they call those Lunchables.
Well, I'm thinking at this point in time, we'd be running out of kid food. And we would be running out of hygiene products like diapers. And we would be running out of IV catheters, pediatric size. If this is a respiratory situation that you describe, we'd probably be running out of neb kits and that type of cannulas and whatnot. Not to mention the ventilator situation, but the kids that we would keep here, those would be the day-to-day things we'd be running out of right now.
So I'm going to ask a stupid question. I know we had somebody from respiratory, I think, on this call, and I am by no means an expert on the world of ventilators, but is there a universal circuit?
We're hearing no on this end. This is Gateway.
That's kind of what I was afraid of, because I'm sure we have about 15 different versions of ventilators, and having a circuit for each as a region would be impossible. So I was hoping maybe there was a one size fits most.
No, we're shaking their heads negative.
Yeah.
Okay.
I don't even think.
I'm gonna ask another question of all the providers, the clinical staff particularly, because EMS side of the house is not as big a problem from my experience. But and Sean was privy to this when we did our conversation with Stars on some of the MedCash trailers. What's the issue if we give you a different type of cannula than you normally would use? Is that gonna like turn your boat upside down if it's coming from a cache? So IV cannula. Sue, Eric.
So Lee, let me get this, Phil. Let me get so I make sure I understand the question that you're asking him. Are you saying that if we, let's say we procure the and we'll say we're doing it from a BJC supply chain management, we get it through Cardinal, but it's a specific type of cannula. Does that change? Are you asking, does that change their ability to use it or not be able to use it?
Right. So from the EMS side of the world, an 18 gauge is an 18 gauge is an 18 gauge. Doesn't matter what it says on the package. But as we found out when we had our work groups on the Missouri side, they were very particular about if you gave them something different, they needed to be trained on it. And yeah, what's the take on that from some of our facilities here? I mean, are your staff going to be able to take an 18 gauge that's from a Cardinal instead of a Medline or whoever and use it? Or, I mean, do you need to retrain them? How critical would that be? How big of an impact is it going to be? Because I know we're all using different vendors and different styles or supplies.
Hey, Lee, they're saying that they'd be able to work through it and it shouldn't be a problem in a lot of cases.
Okay. Because if
Scott.
Yeah, Scott.
Just speaking as a floor nurse, I know when we made the transition here a couple of years ago from what we were using for IVs to what we have now with the BARDs, it took a couple of people back a few steps in regards to being able to, throw it from the other side of the room and stick anybody, just in how it was, packaged and how they had to hold it and everything so they could get it in. But after a couple of starts, most of us that were pretty decent with IV starts we're pretty much right back to it. It's just, give us a couple of times and we usually figure out how to hold how to hold it differently. But like you said, an 18 is an 18. It all goes in pretty much the same. It's just, what are we looking for when we get it in the vein?
Right. And to go like what Phil was asked when he clarified the question for me, that's what I'm looking at is if we purchase things on the grant as a cash and RHCC makes the purchase, we're going to purchase it through our normal supply process because that's pretty much how we kind of have to do it. And we recognize it's going to be different than necessarily what you're used to or what you already have in your facility. And I just want to make sure that we're not going to be like making a bigger hurdle that you can't step over or that it's going to take a ladder to get over, that we need to pre-plan that component of it. I mean, the same thing with, whether it's a difference between an eye gel oropharyngeal or an eye gel blind insertion device, or whether you're using a King or whatever for EMS, it's, make sure and that you can use it. That's kind of where we're trying to get to, is if we cache stuff, I just want to cache one thing and make sure that it's going to work for everybody. Because it's really hard to maintain multiple caches of multiple brands and styles. And
well, I will say, Lee, that under the EMS rules, and the hospitals are required to have a cache of some emergency supplies for the EMS providers. A lot of that is kind of universal. I think if you did buy a cache of some of that stuff that's more universal, but just might have, the safety features activated a different way, that once again, development of a just-in-time training sheet or something for some of those more universal things, I think would be a great idea.
Okay. That's what I want to hear, is that that it's not going to be like, if we have to make a one pager, we have people that they do that. They can make that. I just don't want to have something that all of a sudden people are like, we can't use this. Maybe it won't plug into our stuff. I don't. We ran into that with the vents that we got from the state those vents, a couple of the facilities that I took them to had to change the ends. Boyd had to change the ends on the supply hose to make it interface with their internal systems. And we hadn't thought of that when we had those hoses made. So that again is kind of trying to plan ahead this time so we don't run into that hurdle. So I appreciate that input. So we'll go ahead and try to spin through the last of this real quick because I know we're at our cutoff time. But just looking at this goes kind of back to what Sue said. We're running out of pediatric food, running out of hygiene supplies. Bullet number 2, do you have an MOU or an MOA with other providers? I mean, even if it's something as simple as the local Walmart to be able to get, some No More Tears and some baby wipes and whatnot. What are your resources for at this point? You're definitely going to have some folks who are fretting because of the whole pediatric component and, the long-term mental health. How are we going to keep our providers able to provide? We have those regional resources, but I would say at this point, those regional resources are probably already pretty overtaxed because, again, this is an ongoing issue. What are the other things we could be looking at? And then just what else would you be considering? Anyone?
Oh, it's a lot to ask them. The Lee, I would say this. Because since we are kind of pushing on that time, what I would say is try to take some of this with you. We will push out the I mean, you have the actual sit man, so these questions are there. Because I do want to be cognizant of your time, and we really super appreciate you being here through 3 today. So I would ask that you continue to have that conversation in your small groups there. What we're going to try to do is follow up this specifically with an additional, I want to say a survey, and we'll try to pare it down to be like 10 questions or less, but of some of the highlighted topics that we kind of took out of here, the little gems that we kind of spoke about, talked about, and what we could be seeing in our relatively near future. And we'll use that to help consolidate the mini AAR. I don't want to call it an AAR for a tabletop, but for lack of a better term, the after action / hot wash of this tabletop. So we'll use that to collect some of that data, as well as provide just a few more nuanced points so we can document this today and going forward. So what you guys can expect from us, because I want to try to put a bow tie on this and give some folks an opportunity to say a few things before we depart, is that what you can expect from us is a survey on some of 10 questions or less on what we discussed today, and a few hot wash or after actions items, and a general spot where you guys can put in information. And within 60 days, we're going to try to get this within 30 days. Definitely has to be done before 30 September, but we want to make sure you get a copy of the after actions basic report of this. So when you receive the survey, we're going to keep it open for a week. So expect to receive a survey tomorrow, and basically by close of business the following Friday, we'll ask that you please return that, so we can consolidate all the information and get it uploaded to Asper, and IDPH can have a copy of it as well. So before we fully depart, I'd like to open it up just for any questions, concerns that you may or may not have, and any information that you'd like, or any information that you would like to share. Again, not going to hold you hostage, but I do want to give you guys an opportunity to make a statement before we depart. And I'll put one person on the hot seat. I'll put Greg on the hot seat. Greg, do you have anything for the team?
No, other than just going back to the supplies, I think that would be a great subcommittee to look at items that might be one specific to pediatrics, made up of clinical people who could talk that out and look at, because I think it's a great idea for use of funds to have a cache. Pump tubing isn't universal. Drip tubing is. They do still use drip tubing, don't they? I'm not sure. But I mean, that kind of thing. If you can get clinical from a few multiple facilities, I think that'd be a great subcommittee to have.
All right, thanks, Greg. And with that, I'm not going to hold anybody else to the fire here, but I would like I'll open it up. So if your organization or if you're by yourself, you have a comment, the floor is open. Okay. So if we have no comments, I will say this. One, I'd like to thank everyone for taking their time out today to spend with us in these trying times. I know you guys have meetings upon meetings, because I do every day, and this is just another meeting. But hopefully you got something out of it, even if it was something small. I hope you got something out of it, or just pushed you in the direction of thinking about what can happen with our pediatric population, with schools going back in the, I won't say full swing, but going back in some shape, form, or fashion. So thank you, thank you, thank you. Every little bit that we do on this side of it's going to help us when and if things get bad. So thank you for that. I'd like to thank Lee and Scott for the work they put in on the pediatric annex. We are still taking any comments. So after this, we'll take still some more comments. So if you want to send them our way, we will get them put into the document, and we'll definitely get the draft submitted to ASPR before 30 September. And hopefully we can actually put this into publication. So the goal is to be able to vote on this and pass it and get it done at the coalition level. And I think we'll have no problems with that. Avoid of having nothing, we actually have something. And we have something is because of you guys out there. So again, thanks for everybody for participating. And we're going to end the call here, and we look forward to seeing you in the future. Take care. Bye.